بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. Dear colleagues, ladies and gentlemen, Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, I would like to welcome you here in this scientific gathering, which is very unique. This is the 45th IMC Family Medicine Club. We started almost 4 years ago, and we have been striving throughout the years to bring the valuable topics and the clinical interest that touch the reality of our day-to-day practice as a primary care physician and a family physician. And on your behalf, I would like to thank the Saudi Society for Family and Community Medicine for having the wonderful umbrella of the scientific umbrella to have this kind of scientific event. And I would like to thank Sandus for sponsoring this event and the wonderful organization by Fexus. Of course, when we talk about the topic today, it's very important for us because respiratory tract infection usually remain among the most common reason for patient visiting the primary health care. But unfortunately, there is antibiotic overuse and sometimes an abuse. And when we dig deeply in this, we find the reason could be because of many of us or our colleagues, they don't know how to differentiate between the clinical presentations of bacterial versus viral. And sometimes it is because of the patient that demanding to have antibiotics where there is no medical justification and rationale. So this kind of abuse and misuse comes into the site that reflected into bacterial resistant, which is very crucial for us. And unfortunately, because of these microbial resistant, it will be also subjecting our patients to have the complications of using big guns because of this resistant, and ultimately will be burden our healthcare system with a lot of financials. And if you are working in a private sector, you always focus on the cost effectiveness. And we will be, witnessing the insurance company, they are talking about the average claim cost for the patients if you are dealing with patients with a high cost. So these are the consequences of the overuse of our antibiotics. And of course, antibiotics, one of the big guns and the big weapons that we can use it efficiently to secure the safety of our patients. So in these sessions, we are going to be equipped with the evidence-based information and expertise to know how to choose and to prescribe the proper antibiotics in order to make the balance between the clinical efficacy and the patient safety. So we have been privileged here today to have 3 of our distinguished speakers, in fact, representing 3 different specialty: family medicine, pulmonology, and pharmaceuticals. And with this wonderful expertise, I'm sure that our gathering today will be quite rich and scientifically very informative. And I would like to welcome you all here attending these sessions, and I would like to welcome our online attendees. There are going to be almost 1,000 of them attending our session. So without any further ado, I would like to encourage you to actively participate and ask questions and engage in interactive dialogues at the end of this session. So please prepare your questions as we go. And I would like to ask the online attendees to put the questions in the Q&A box so we'll be able to provide it to our guest speakers. Of course, we will start with the first presentations. It's for Dr. Badr bin Hamd. He's a well-known figure in the scientific activities and medical educations. He has been participating with us in a lot of activities locally and internationally. And he's a consultant family medicine. He's a senior consultant family medicine and the chairman of the family medicine department in the International Medical Center in Jeddah. And we have also Dr. Mariam Sheikh. She is a consultant pulmonology and a critical care in the International Medical Center in Jeddah. And we have Dr. Muhammad Mahbub. He's an expert medical advisor. And I'm very sure that their contribution will be quite interesting for all of us. So for the first presentation, I would like to welcome Dr. Badr to have his first presentation. And we will go subsequently, right on time to finish, inshallah, in time. So thank you, Dr. Badr, for accepting our invitations, and I would like to leave the floor for you.
Thank you, Dr. Asha, for this introduction. Thank you for organizing committee and for Sandoz Company for organizing this scientific meeting. So can we have the presentation, please? So Bismillah ar-Rahman ar-Rahim. So my presentation will be in 3 parts. We'll start with small introduction, then I will concentrate on talking about acute pharyngitis in specific, and we will end by talking about ceftriaxone role in upper respiratory tract infection. As we know that upper respiratory tract infection has many types and can affect many sites from upper and lower respiratory tract infection, starting from very mild infection like rhinitis, sometimes common cold, moving toward serious and life-threatening infection like epiglottitis. So as physician, we need to figure out what type really of infection the patient is suffering from. So our role as physician in general is to prepare ourselves in taking really a detailed history from our patient, and then after that proceed to ENT examination. Always I say we need to do full ENT examination, not only the throat, not only the ear, not only the nose, but the whole ENT examination. And then after that we should decide about whether we need to take any investigation like nasal swab, throat swab, or culture, and we'll discuss this in detail in the coming slide. And finally, we should also decide whether our patient need to have a CT scan for the sinuses or chest X-ray to rule out any infection. So the second part is about acute pharyngitis. So acute pharyngitis, as we know, it's one of the common conditions that we encounter in our clinic as a family physician, as internists, as pulmonologists. So most of us, we are seeing common cold or rhinitis or any type of acute pharyngitis in our clinic, and most of the cases, almost 90% of the cases, is caused by respiratory infection. And the challenge here is how to differentiate between viral and bacterial infection, especially group A Streptococcus, and we'll talk and discuss why specifically group A Streptococcus is very important to distinguish from other infection. So this is our big challenge. So this is the challenging part, which is differentiation between viral and bacterial and excluding other causes. So if we want to define the causes of acute pharyngitis, we can divide it to infectious and non-infectious. Moving to talk about the infectious, most of the causes, 90% of the causes of the infectious cause behind acute pharyngitis is viral infection, mostly adenovirus, rhinovirus, coronavirus, of course, influenza A and B, which is really commonly seen in our clinics. So what about the symptoms? Mostly the patient will come to us with sore throat, fatigue, nasal congestion, and cough. In addition to that, sometimes the patient will have sneezing, complicated by viral conjunctivitis, hoarseness of voice, and this can be complicated by viral sinusitis or bronchitis. And some of the patient will develop rash. We call it viral exanthems. And of course, of other patients will have fever, cervical lymphadenopathy, and other patients will have, as we said, specific rash, and all of these could be happened in the first day or even after 5 days. That's why the follow-up is very important within the first 5 days. What about other viruses that can really cause acute pharyngitis, like Epstein-Barr virus? Of course, pharyngitis is a prominent feature of epivirus, and the patient will present most of the time. It's not a common condition in our practice, okay? We're not seeing this frequently. Maybe I saw it maybe once or twice, okay? So the patient usually will come to us with mild to moderate fever, patchy pharyngeal exudate. Sometimes there will be tonsillar swelling, as we can see here, which is almost similar to tonsillitis. And of course, sometimes there will be splenomegaly and atypical lymphocytosis. That's why we need really to examine our patient thoroughly and not depend only on examining the throat. So I don't want to go deeper in this table, but at least we have multiple features that can differentiate between acute tonsillitis, which is almost, as we can see here, similar to epivirus, okay, and infectious mononucleosis. And the main feature, as we can see here, the Rash, splenomegaly, hepatomegaly is mostly common infectious mononucleosis. There is also EBI serology and monotest, okay, which is mostly positive with infectious mononucleosis. Of course, if you take a throat swab, or sorry, a throat culture, it will be positive with patient with tonsillitis. So it's very critical to differentiate between both infection, because if you give the patient ampicillin or amoxicillin, it can lead to more complications. So what about herpes simplex virus? Another virus that it's really common in our practice. We are seeing this mostly. So the patient will present with this, like mouth, labial and gingival ulcer, or even vesicles. And sometimes the patient will have pharyngitis. So of course, it's self-limiting. You can give some antiviral medication, keep it in your mind. Moving to the other part, which is a bacterial causes, mostly it's a group A streptococcus, which is accounting for 15% more or less. And the classic symptom, the patient will come to us with sudden acute onset of fever, throat pain, fatigability. Sometimes there will be tonsillar oxidate. Of course, with anterior cervical lymphadenopathy. Other features that support the diagnosis include petechiae and rash, and of course, and this is mostly in pediatric, which is a strawberry tongue. We call it scarlet fever. So all of these features that support the diagnosis of group A streptococcus infection. So why we're talking about group A streptococcus infection? Because it has suppurative complication and non-suppurative complication. Suppurative complication like otitis media, peritonsillar cellulitis, or abscess, sinusitis, and even life-threatening condition like meningitis. Non-suppurative, we are talking here about autoimmune diseases or immune-mediated, which is including rheumatic fever and glomerulonephritis. That's why early detection and early treatment is very important, especially in pediatric. So what about other bacterial infection? We have also, we talked about group A streptococcus infection. We have group C, and group G is not that much common like group A. It could be discovered by throat swab. It's almost similar in the symptoms, but the main difference that it cannot cause acute rheumatic fever or even glomerulonephritis. Other bacterial, I will not say rare, but it's uncommon bacterial infection, but I'm just mentioning this bacterial infection if you discover it through the culture. The only difference here is that the most of the treatment of choice is not amoxicillin, is not cephalosporin, other. The main treatment here is erythromycin. So if this is uncommon, this is rare, I didn't face it in my lab, but if we face it through the culture, so we need to remember that erythromycin is a treatment of choice for this bacteria. Okay, of course, if we can see here, so this patient, the corynebacterial diphtheria, it was common maybe years back, but now, I mean, in the last 10 years, I didn't see any case of diphtheria, but it's important to be mentioned. So the patient will present with pharyngitis, low-grade fever, malaise, cervical neuropathy, and the hallmark of diphtheria, as we can see here, is the formation of tightly adherent gray membrane that bleed when dislodged. Of course, this is very important to be diagnosed from the beginning, especially in endemic area. So what about STI, sexually transmitted infection? So HIV, okay, the pharyngitis is not common, but one of the presentation of HIV is mucocutaneous ulcers and pharyngitis. So it could be a presenting symptom for patient coming with HIV. What about Neisseria gonorrhea? The prevalence of pharyngeal gonorrhea is reported in about 15% among men who have sex with men. All of the majority of cases are asymptomatic. Again, it's not common really in our practice, but here comes the importance of taking thorough history for our patient, and some symptoms of gonococcal pharyngitis are non-specific, as we know, and include the same, almost the same symptoms of pharyngitis, but here comes the importance of taking detailed history, doing the examination, and you need here to do, of course, throat culture and other investigation. Treponema pallidum, which is a causative agent of syphilis. Of course, it's a rare cause of pharyngitis. Okay, however, syphilis rates are rising, particularly among men and of course, men having sex with men and persons with HIV infection. And pharyngitis is affecting almost 50% of patients with secondary syphilis. Again, we need to pay attention to such case. I will have here, as we can see during examination, there will be mucus patchy, round or oval elevated regions covered by pink or gray membranes. So we need to pay attention to the history of our patients. So from simple pharyngitis to patient with syphilis. So what about non-infectious causes? So non-infectious causes range from simple things to autoimmune infection like allergic rhinitis, sinusitis, reflux, smoking, exposure to smoke or exposure to dry air. It can be caused by trauma. It can be caused sometimes by some medication like ACE inhibitor or autoimmune disease like Kawasaki disease. Again and again, history and examination is very important. So how to evaluate patient with upper respiratory tract infection? So you have the clinical assessment, which is very important, and that's account for 95% of taking the decision about how to treat your patient, and 5% more or less is about the investigations. So again, don't memorize this table. You can make it by yourself, very simple, but you need to keep it in your mind. How to differentiate between viral and bacterial infection? Mostly the nasal discharge, usually in viral infection will be clear and watery. The sore throat is common in both. Cough is more frequent in viral in comparison to bacterial. Systemic symptoms, almost the same duration. We are talking about almost the same duration. It's a little bit tricky. That's why close follow-up for your patient is very important. As I said, within 3 to 5 days, just to differentiate between viral and bacterial infection. Please keep in mind this red flags. Once you face the red flag in the clinic, please don't wait. Refer the patient directly to emergency. So patient will present with you with muffled voice, drooling or pulling of saliva, stridor, respiratory distress like tachycardia, dyspnea, and muscle retraction. Okay, tripod position as we can see here. So this patient is having almost epiglottitis. Please don't wait and don't follow up this patient. Just refer this patient directly to emergency. Also, as a red flag, we are talking here about deep neck space infection. So we have peritonsillar abscess, submandibular abscess, retropharyngeal abscess, parapharyngeal space infection, and finally epiglottitis. So the symptoms and sign is almost similar. The patient will present to us with severe sore throat, fever, muffled voice, ear pain. The patient looks toxic. The patient he looks ill. Of course, in peritonsillar abscess, examination will show severely swollen tonsil. A submandibular abscess, you will have palpable crepitus may be present in submandibular area. Retropharyngeal abscess, there will be swelling, severe swelling in the area. And in parapharyngeal space infection, the patient will complain of severe dyspnea. And of course, epiglottitis, there will be muffled voice, drooling, stridor, and even the patient will be in severe distress. So please, once you have any one of these signs, don't wait, just refer the patient immediately to emergency. So what other criteria that could help us? What we call center criteria for group A Streptococcus. So it will help us to determine whom to test for group A Streptococcus. So this is in the American guideline. Okay, they prefer not to start with empirical treatment without having a microbiological evidence about the bacterial infection, of course supported by the sign and symptoms. So this is the central criteria. So mostly you will have tonsillar exudate, tender anterior cervical neuropathy, fever, and absence of cough. So all of this will go in favor of bacterial infection. So what is the difference here? So the Infectious Disease Society of American and American Heart Association, they recommend that the clinical judgment will guide you to decide about the testing. And then after that, based on the test, you will decide about the management. The European is more practical, and most of our practice here, especially in this area, is mostly from the European. So the European will depend on center criteria, and they will depend on the clinical judgment, history, and examination to decide about the treatment. So I just simplified in this simple algorithm. So if you want to treat acute bacterial infection, group A strep infection, the European will go by clinical judgment and central criteria to decide directly about the treatment. The American will use the clinical judgment to decide about the test, then after that, decide about the management. So what test do we have? practically speaking, just if you want to do any test, okay? So for example, in primary care, as I was working before, we don't have more sophisticated tests, and even sometimes we don't have the swab. Maybe in secondary or tertiary hospital, you find drug therapy test, which is really popular, and we are using this from time to time, not with every patient, but with specific patient when there is uncertainty about the case. NAT, which is nucleic acid amplifying test, I didn't use it in my life, but it's mentioned there and we should mention it. It's highly specific, and it's very important to mention here that once the rapid test is positive, that means the patient is positive, because false positive are uncommon. So the important practical question, when to confirm negative rapid test. Okay, so if you took swab from your patient and the rapid test is negative, so confirming a negative rapid test can be done through the culture or not for specific patient, those with rheumatic heart fever or immunocompromised, or those in contact with those patients. Of course, with patient living in area with endemic with acute rheumatic fever, patient in whom clinical suspicion for group A streptococcus is high despite negative rapid test. We need to keep in mind that if you want to do culture will take almost 1 to 3 days. So keep this in your mind. And with proper collection, the sensitivity on specificity of the culture reach 95%. What about NAT? NAT is very highly specific and sensitive. That's why false positive is high. So if you want to use it, okay, it's uncommon, but if you want to use it, you should keep this in your mind. One of the other tools that could be ordered for the patient to differentiate between viral and bacterial, which is C-reactive protein. Once the C-reactive protein is almost 100 and above, this will go in favor of bacterial infection. So other investigation that could be used in the clinic, CBC, of course, if there is a neutrophilia, it goes with bacterial infection more. Procalcitonin, mainly it's used in inpatient rather than outpatient. We're not using this frequently in outpatient. Nasal swab is frequently used before in COVID time, where we're using the PCR, now we're using the antigen to detect COVID virus and influenza A and B. Again, it depends on your clinical judgment. If it's obvious for you, no need to do it. If you're uncertain, okay, or you want to have a documentation about the organism, you can do it, but it's not like before frequently used. And finally, chest X-ray is your decision to differentiate whether the patient is having pneumonia or other infections. So this is your clinical judgment. So just to summarize and wrap it up, when to use this if you are uncertain about the patient or in severe presentation, mostly severe presentation, those patients who need query or to be admitted, and of course, high risk patient. So the last part of my presentation, we need to answer this question. We are using many molecules of antibiotic, many types of antibiotic, many classes of antibiotic. So the question here, is cefuroxime still relevant in treatment of upper respiratory tract infection? The answer is yes, it's relevant. Okay, I'm talking here really practically speaking. Yes, we are using this for pediatric, for adult, for different causes or different infection, and really still helpful, alhamdulillah. So just to remind ourselves that cefuroxime is considered as second-generation cephalosporin, covering an active against beta-lactamase producing organism like Haemophilus influenza, Monoxide catarrhalis, group A, Streptococcus pharyngitis, Streptococcus pneumonia. Studies show that oral cefuroxime achieve almost 89% clinical cure improvement in upper respiratory infections such as sinusitis, pharyngitis, tonsillitis, and otitis media. So it's a good option, but we need to use it wisely, and we need to know exactly when to use it and in which condition. So these are the main conditions that you can use cefuroxime. So you can use it in acute bacterial sinusitis, otitis media, tonsillitis, pharyngitis, and in some cases of acute bacterial exacerbation of chronic bronchitis. And Dr. Mariam will elaborate more in this, inshallah. But it is good medication. But still, in most of these cases, if the patient doesn't have any allergy to penicillin, still you can use amoxicillin and augmentin, of course, as one of the first option in these cases. So my last slide, why again cefuroxime? Cefuroxime because we have different forms and concentration that make it easy for you and practical to select between different doses and different forms for your patients. So we have available as various formulation, including oral tablet, oral suspension, and powder for injection. Of course, we have the 250 and 500, and this gives you the flexibility in selecting the proper doses for your patients, especially nowadays. Most of the guideline is moving toward lower effective dose and with effective duration. And finally, of course, if once you have an oral suspension, especially for those who cannot use the tablet, and of course, for pediatric patient. Thank you so much. This was my last slide.
Thank you so much, Dr. Badr, for this wonderful presentation. You have highlighted the upper respiratory tract infection management using cefuroxime. And majority of our cases we encounter are upper respiratory tract infections, but there is some of it are lower respiratory tract infection, and this will be the second part of our scientific event to highlight the role of cefuroxime in the management of lower respiratory tract infection in primary care. And here we have Dr. Mariam Sheikh, who is a consultant pulmonology and critical care in the International Medical Center. And on your behalf, I would like to thank her for giving us her time and expertise, to shed a light on this very important part. And I'm very sure that it will be quite helpful for all the primary care physicians. So thank you, Dr. Mariam. I'll leave the floor for you.
Assalamu alaikum, good evening. Thank you for coming to this interesting lecture, and thank you, Dr. Ashraf, for this kind presentation. Should I point it here? Okay. So tonight, inshallah, we'll be talking about lower respiratory tract infection in primary care. In other words, I'll be mostly talking about community-acquired pneumonia as outpatient management, basically. So first of all, I want to thank Sandoz also for this presentation as part of my disclosure of interest. And my presentation will be based on two most important references worldwide. It would be the ATS guidelines, and this last publication was 2019. We're waiting for the 2025 publication very soon, inshallah. And the second one will be the IDSA that was reviewed 2023 as last one. So basically, when we talk about pneumonia, we need a clear definition, and we all know the definition of pneumonia. It's a clinical signs and symptoms, plus a radiographic confirmation of infiltrates or consolidations. So basically, both guidelines agree on having a radiological confirmation before saying it's a pneumonia, because unfortunately, we're seeing a lot of patients coming to the clinic saying that I had 3 times pneumonia in the last year, 5 times pneumonia in the last 5 years, and then you will think of, was it confirmed? I was treated as a pneumonia for 10 days of antibiotics. Should I screen this patient, for example, for immunodeficiency? Because like 5 times or 3 times pneumonia in 1 year is so much. So we need a clear definition of pneumonia, the respiratory symptoms, at least one, the signs, the abnormal lung sounds, the fever, physical exam and history is very, very important, as well as chest X-ray findings. So now we have a clear pneumonia in your clinic, and the next question would be, should I admit this patient or should I treat him as outpatient? So basically this question will be answered very simply. It's 2 main score to classify our pneumonia. We all know the curve 65, and we all know the pneumonia severity index. So curve 65 seems very easy, very simple, just based on history. And we have also the modified curve 65 without the urea level. So basically, if the patient is 2 and above, so it needs to be admitted. If it's less than 2, he can be managed as outpatient very safely. The pneumonia severity index seems more complicated, but there is a calculator for that. And it tackles also clinical signs and symptoms of pneumonia, as well as some radiographic and laboratory finding. So when to do laboratory test, it's basically based on the previous manifestation. If you think that your patient is more toward to be like a severe pneumonia and needs to be admitted, so at that time you need to confirm it with a lab test, but not always. So which one we should use in the clinic? For the pneumonia severity index, of course, if it's 4 and above, we need to treat as inpatient. Which one should be used? So although CURB 65 seems much easier, unfortunately, the PSI, the pneumonia severity index, has the highest evidence and the most studied one, with 2 very big randomized control studies worldwide. As for the CURB 65, we're still having some conditional recommendation using it in the clinic or in the emergency even. So basically, we decided now that our patient is going to be treated as outpatient, okay? So the second question would come to the mind in the clinic, what kind of investigation we need to do? So do we have family medicine here? Only you? So it's going to be Dr. Sayed. Okay. Okay, so basically, this is the second question that would come directly to the mind. Do we need to take respiratory culture? Do we need to take blood culture? Do I need to do inflammatory markers, procalcitonin, CRP? Should we test for influenza, for coronavirus? Should we test for Legionella? Should we test for Streptococcus? So to answer these questions, the guidelines were very clear in their recommendation, but unfortunately, most of them are strong recommendation, but with a low evidence. What do I mean by low evidence? Dr. Ashraf mentioned that community-acquired pneumonia is the most common disease that we've seen, or even like respiratory infection in the clinics. Unfortunately, we don't have a lot of RCTs. I don't know why, even worldwide. So, but most of the studies are extrapolated from the inpatient management and evaluation. So basically, but the recommendations are very clear. How about respiratory culture? So basically, we don't need to do respiratory culture very clearly for patient and outpatient management. How about a blood culture? Of course, we don't need to do also blood cultures. Once we decided it's going to be an outpatient management. How about urinary antigen? We do it for Legionella only in outbreaks. So for example, if the Ministry of Health declared that we have an outbreak of Legionella, and it might happen anytime, so at that time we need to test every patient who comes with a pneumonia, infiltrates or consolidation on a chest X-ray. How about influenza test? So basically, when I have a patient, let's all agree that it's very hard to differentiate between sometimes bacterial and viral pneumonia. They all come with some nasal congestion. Sometimes it starts as upper respiratory, sometimes very vague symptoms, and then everyone is coming as coughing and phlegm production and some like shortness of breath or not. And we have an infiltrate on the chest X-ray. So should we test for influenza? So actually the guidelines said yes, if you are in the flu season, you should test for influenza using the PCR, not the antigen itself, okay? So I think Jeddah is always the flu season, right? We're different from the whole world because we bring the word two seasons, basically. Exactly. So, and then after the Hajj, basically. So yeah, it's different from the whole world. So how about procalcitonin? No, we don't need to wait until we have high procalcitonin to start antibiotic. We can just start empirically the antimicrobial treatment. The IDSA also came up with the same recommendation during 2023, the final panel, with the same one: no need for blood culture, no need for respiratory culture, unless we're talking about severe cases, and this is different. No need for influenza unless we're talking about flu season as well as COVID, and for Legionella unless we have an outbreak. How do we manage pneumonia? So I decided that my patient is fine for outpatient management. I did not need to do any test except, for example, for influenza if I have the season, or Legionella if I have an outbreak. So what kind of antibiotic I would give to him? So before searching for the antibiotic, I think we need to ask, what am I targeting? What is the most common germ-causing community-acquired pneumonia? So worldwide, we all know it's Streptococcus pneumonia. Saudi Arabia still, the most common cause is Streptococcus pneumonia. But for example, in other countries, sometimes it might be different. In this comparative observational study between Spain and Canada, actually in Spain, Streptococcus was the most common, but in Canada, Mycoplasma and Chlamydia were the most common germ, and not Streptococcus pneumonia. So the coverage would be different based on the endemic area we're living in. Other consideration also, we need to take into consideration our patient comorbidities. So for example, if I have a patient with COPD, I would think of covering beta-lactamase hemophilus. If I have someone with bronchiectasis, we need to think of Moraxella, for example, and even Pseudomonas. If I have a patient post-virus, we have to think of Staph aureus. And in malnourished patient and elderly, we need to think of gram-negative bacteria, as well as for aspiration pneumonia possibility. So here we have our germ, we have our target, what to give as antibiotic. Again, unfortunately, there is no much studies. If anyone would put like coronary artery disease or treatment or management of coronary artery disease, might find like thousands of RCTs. I don't know why in pneumonia, outpatient pneumonia management, most of the data are extrapolated from the inpatient management, and here we go with just a small sample size RCTs. So we divide our patient into two groups, either just young and healthy, or adults and healthy with no comorbidities, with a pneumonia, or adults with comorbidities and pneumonia. And here we can decide what kind of protocol we should go. So let's go for the first patient without comorbidities. What would you give him? One single agent antibiotic, dual antibiotics, or what kind of antibiotic you would give him? Any idea, any answer? Okay.
Most people will go with, practically will go with quinolones, but of course the first line we know we give the amoxicillin and augmenting amoxicillin plus glabellic acid. But this is the first line. Practically what we are seeing is patient, some physician will jump directly to prescribe quinolones. Both really works effectively. Of course, some in other guidelines, okay, a patient will respond very well to start with macrolide, but of course we know the area here in Gulf area, we have high resistance to macrolide. That's why we are shifting more and more to like amoxicillin plus clavulanic acid as a combination therapy with macrolides. This is an option. Or directly we are jumping to quinolones. This is the practice, this is what we are seeing.
Yeah, actually, yes, Dr. Badr, most of what we're seeing is just fluoroquinolones most of the time. And sometimes combination therapy, and sometimes nothing. So I will start just with a small fact, which is a scary fact, that the latest data coming from the American Thoracic Society and the National Institute of Health, that as comparing the speed of having resistance to antimicrobials and the speed of having new antimicrobial, new antibiotics, basically by 2050, okay, every 1 second, one patient will die from antibiotic resistance. So this is very interesting. Okay, so basically treating outpatient with no comorbidities, healthy, just with a pneumonia, the first regimen is just amoxicillin actually, and this is based on inpatient treatment and a very long track of like safety of this antimicrobials. The second one is doxycycline, although we don't have a lot of data, but it's working well in most of the countries. And this is the ATS guidelines, by the way, as well the IDSA. And last one is macrolide. But macrolide, it needs to be considered only, we're talking about or one single monotherapy. Macrolide, if we're in region less than 25% of strep resistance. Basically, for example, in the United States, they have more than 30% resistance, so they stopped using macrolide as a single monotherapy for pneumonia ever. In Saudi Arabia, we have different data. I think one of the studies in Riyadh came up with 17% resistance, in Khobar 40% resistance, in some other areas, so they ended up with more than 30%. Although it's still there in the Ministry of Health recommendation, but we're talking more about eliminating macrolide from management of community-acquired pneumonia. So most of the countries are not using it anymore because of high resistance. Outpatient with comorbidities. whatever comorbidities, diabetes, hypertension, COPD, whatever comorbidities, we have two regimens, either the combination, beta-lactams plus macrolide or doxycycline, or the monotherapy quinolones, okay? Is there any regimen favored over the other one? As we said, unfortunately, we don't have a lot of comparative studies, but what we can say is, what's the benefit of each one? What the advantages of each one? So the combination is very good against resistant strep pneumonia, against beta-lactamase Haemophilus, against many enteric gram-negative bacillus, and against MSSA, of course, as well as the atypical pathogen. How about levofloxacin? In this regimen, we need to take into consideration that we're going to take 3 or 4 tablets of medication every day for 5 days, or even 7 days. Fluoroquinolone has the broad coverage, of course. It's an excellent bioavailability agent and one daily dosing convenience, and it has definitely effectivity against beta-lactamase producers. So if the choice would be, if I am a patient, I would choose, of course, the levofloxacin. But nowadays, there is a lot of data talking about warnings in elderly, in patients with vascular diseases, and with many other comorbidities, mostly vascular diseases and old ages. So basically, despite all these warnings, the ATS still including fluoroquinolone as equal as the combination beta-lactams plus macrolide or doxycycline, and not yet changed. I think it will be changed in the newest guidelines, inshallah 2025. But as for the US FDA, they said use the combination, okay, and choose it individually and try to avoid the fluoroquinolone in most elderlies, and because we have a lot of adverse event being reported nowadays. Second question would be, I have a patient in the clinic. Sorry, okay. Need to go back? No, how can I go back? Okay. Okay. So I have a patient now who is diagnosed with community-acquired pneumonia, signs and symptoms, chest X-ray showing infiltrates, and it's the flu season, so he tested positive for influenza A, for example. And what should I consider him? Is it community-acquired pneumonia, or is it influenza pneumonia, or what should I do? Should I give him just antiviral and antibiotics, or just antibiotics without antiviral? What would you do?
It depends on how can you follow up your patients.
Okay.
The practice, mostly they are giving combined. They are giving the antiviral and antibiotic. Sorry. So in practice, we're giving both. Okay, unless we can and we ensure that we can follow up the patient is stable, young, he doesn't have comorbidities. The criteria is to be treated as outpatient, and we know exactly that the patient can really have a close follow-up for us. Otherwise, okay, it will be a mixed management, antiviral and bacterial.
And antibacterial. So basically, yeah, 100%. If a patient has a community-acquired pneumonia and he tested positive for influenza, for inpatient, yes, it's a strong recommendation to use anti-influenza treatment. And previously, maybe everyone remember that oseltamivir might not work beyond 48 hours, and if it's too late in the disease, don't use it, etc. But the guidelines are very clear. Independent of the duration of the disease, if he tested positive with infiltrate on chest X-ray, give him the oseltamivir as inpatient. As for the outpatient, as we said, it's a conditional recommendation. Risk versus benefit. It doesn't have a lot of side effects so far. But if he's young, healthy, with no much comorbidities, not immunosuppressed, I think we can just go with antibiotics. Otherwise, you can use safely both antibiotic and antiviral, and no one will blame us, of course. How about the question, in other words, actually, if a patient with influenza and he got diagnosed with community-acquired pneumonia, so they answered this question from both ways. So yes, because sometimes his influenza, okay, this is influenza, I don't need to give him antibiotics. No, it should be covered with antimicrobials and mostly the combination to make sure that he is covered for MSSA. So far, alhamdulillah, we don't have a lot of community-acquired MRSA in the area, so mostly we're tackling MSSA. This is the Ministry of Health recommendation. I think it was reviewed 2021. So for patient healthy, with no comorbidities and no previous antimicrobials over the past 3 months, we have the similar regimen, either amoxicillin or macrolide or doxycycline, but I think macrolide will be removed because of the high streptococcus resistance in the region. As for the outpatient with comorbidities, we have these regimens, cefuroxime plus one of the macrolides, or amoxicillin plus one of the macrolides, or augmentin plus one of the macrolides, or amoxicillin clavulanate. And in case of allergy, so they insisted here, so we don't have to forget that we are endemic for tuberculosis. And levofloxacin might mask tuberculosis. That's one of the treatment actually, and we don't need to increase resistance of tuberculosis against levofloxacin. So basically the Ministry of Health said if patient has allergy to one of these regimen, the above mentioned regimen, at that time give him the fluoroquinolone. As for even in severe community-acquired pneumonia, by the way, now they are in favor of combination of amoxicillin clavulanate plus macrolide instead of plus levofloxacin because of the immunomodulatory effect of macrolide as well as the side effects of levofloxacin. Again, in the ATS, they did not favor any regimen over the other so far. How about cefuroxime? I think Dr. Badr mentioned the coverage of cefuroxime, and it's very important to know that it's covering beta-lactamase Haemophilus influenza, as well as beta-lactamase moraxella, and it covers both gram-positive and gram-negative bacteria, and it's been there since 1987, I guess. The National Institute of Health published 2024 emphasized on the point that ATS and ITSA both endorsed cefuroxime as one of the primary regimen of treating pneumonia, community-acquired pneumonia in outpatient, covering all these pathogens, of course. And thank you. I did not mention anything about bronchitis because it's a very debatable point. Basically, bronchitis wouldn't be covered with antibiotics unless you have a severe COPD exacerbation. So just keep it always in your mind. And we talked here about pneumonia with infiltration and consolidation on chest X-rays. Thank you.
Thank you so much, Dr. Mariam. And now we're moving to the last important presentation by Dr. Muhammad Mahbub. He's an expert medical advisor, nephrology, transplant, and endocrinology, diabetes, and infectious disease. He will shed more light on cefuroxime. So thank you. I will leave the floor for you.
Thank you so much, Dr. Ashraf, for giving us this opportunity. My name is Muhammad Mahbub. I'm the medical advisor for Sandoz. And today we're going to have our vision in cefuroxime as Zinat with the power of heritage and quality, with more than 35 years of experience since the launch in 1987. With that, we'll start with a small video about Sandoz.
At Sandoz, we have a clear purpose: pioneering access for patients. It shines through in our heritage of medical breakthroughs and in our plans for the future. We pioneer access by leading the world in off-patent pharmaceuticals, making high-quality, cutting-edge medicines accessible to more patients, whenever and wherever they need them, and at prices they can afford. Healthcare has advanced dramatically over the last century, but humankind is increasingly confronted with new challenges. A growing and aging population, the rapid spread of new health threats, even a resurgence of illnesses we believed we had beaten. Our comprehensive portfolio of around 1,500 products covers most major therapeutic areas and is available in over 100 countries. It makes a real difference for patients and healthcare systems worldwide. And as the global pioneer of biosimilars, we've opened up a new market, one of the fastest growing segments in healthcare today. Whatever we do, we put the needs of patients first. That's how we create value for patients and healthcare systems, as well as for our customers, employees, partners, and ultimately our owners. We are powered by the commitment of around 22,000 individuals who embrace diversity. We're a team with a common purpose, inspired to make a difference. For a world that needs affordable, sustainable, and high-quality healthcare more than ever before, we are progressing further, going faster, pioneering access for patients.
So as Sandoz, the house of antibiotics, would like also to welcome the original cefuroxime acquired from GSK. We are the first company to produce penicillin in the world in the early 50s, and with this heritage, more than 70 years of experience in antibiotics. Particularly if we are talking about Zinat, with more than 35 years of experience in treating patients, prescribed in more than 100 countries all over the world, we would like, as Sandoz, the home of antibiotics, to welcome Zinat in our portfolio. I believe Dr. Bell and Dr. Mariam were talking about also the growing antimicrobial resistance. As a global leader for antibiotics, Sandoz is committed to tackle the problem of the antimicrobial resistance. It is also estimated that more than 50% of antibiotics are used inappropriately, thus contributing to the spread of antimicrobial resistance. We, as Sandoz, also is committed to the antimicrobial stewardship by offering the range of antibiotics in various formulations to meet individual patient needs, while also promoting the rational use of antibiotics. So the tailoring the treatment as a strategy to prevent the antimicrobial resistance, if we are talking about Zinat as a second-generation cephalosporin with the balanced spectrum of activity against gram-positive and gram-negative, unlike the first generation that focuses mainly on the gram-positive, while the third generation focuses mainly on gram-negative bacteria. Also, with the bactericidal mechanism of action, unlike the macrolides that have a bacteriostatic action that inhibits the growth of bacteria, with more than 90% high eradication efficiency. As Zinat is proven efficacy across bacterial infection in the upper and lower respiratory tract infection, urinary tract infection, and skin soft tissue infections. When considering cephalosporins for the treatment of upper respiratory tract infections, Zinat provides a spectrum coverage against the key upper respiratory tract infection pathogens. Also, the Streptococcus pyogenes isolate showed higher susceptibility to cefuroxime than macrolides and cefaclor and cefixime, as well as it achieved the adequate penetration in the infected sinus tissues, tonsillar tissue, and middle area fusion. If we talk in a quick brief, if we'd like to spot the light on tonsillitis due to the group A, unlike penicillins, it eradicates the aerobic beta-lactamase producing bacteria and preserves the interfering organisms as alpha hemolytic Streptococcus. Moving to the acute bacterial sinusitis, so the adequate coverage against the key acute bacterial sinusitis pathogens. Also, it penetrates adequately and uniformly into the chronically inflamed sinus mucosa, unaffected by the degree of inflammation, as well as it exceeds the MC90 for those cases. Moving to the otitis media, as you all know, the key pathogens are mainly extracellular. So if we compare to macrolides that mainly accumulate intracellularly, whereas the beta-lactams like cefuroxime mainly penetrate the extracellular spaces and help to achieve bacterial eradication in the middle ear fluid. Moving to the lower respiratory tract infections, key pathogens are covered. As mentioned by Dr. Mariam, the Haemophilus influenza, followed by pneumonia, and Moraxella catarrhalis. It has also clinical success rates was similar to the third generation cephalosporins with the acute exacerbation of chronic bronchitis, we're considering the cefuroxime acetyl. Also, it has a favorable safety profile in adults and children. As you all know, it's category B in pregnancy, as well as with no hepatic metabolism. It is a very good option for patients with hepatic impairment, as well as the elderly patients taking multiple medicine for chronic diseases. Also, compared to cefuroxime, with the significantly lower, most frequent adverse event diarrhea, it shows better tolerability compared to cefuroxime. With 35 years of experience, not all cefuroxime are the same. With the innovative druggies covered by the innovative rapid rupture film coated, which serves to mask the bitter taste of cefuroxime, as well as improves the bioavailability to prevent the dose dumping on the gelling in the GI tract to achieve the optimal absorption for our patients. Also with a range of formulation with either the tablet, film-coated tablet 250 and 500, as well as for the granule for the oral suspension, we have to 125 and 250 oral suspension. With that, I would like to summarize my slides with 35 years of experience, the balanced broad spectrum coverage, as well as the range of formulation, and the very well-established safety profile for children, adults, and elderly. Thank you so much.
Okay, thank you so much, Dr. Mohammed. Now I would like to invite the three speakers to be on the stage here so we can open the Q&A session. And we have a couple of questions from our online audience, but I will leave the floor now for the questions from the audience here. Any questions? Any question from here? أهلا بسؤال. Yes, we have one question here. Mike.
Assalamu alaikum. Thank you very much for these presentations of all. My question about practical use of doxycycline. Somebody using the doxycycline here in Saudi Arabia because they have some problems with doxycycline?
Dermatologist.
How much is using it?
Actually, we're using it frequently in the inpatient for coverage of pneumonia. You know, like a lot of patients have like cardiac diseases, QT prolongation. So in these patients, we avoid macrolides, and we go more for doxycycline, I mean, with a combination of amoxicillin clavulanate or even other coverage. So in elderly with multiple comorbidities, sometimes we don't like really macrolides, mostly with cardiac diseases and QT prolongation. So mostly used in inpatient. And allergic patient, of course, we are using doxycycline.
Okay, any other questions? Okay, I have a couple of questions here from the audience. The first question is, in what situation would cefuroxime be preferred over amoxicillin clavulanic acid for respiratory tracts? Anyone?
I would say GI tolerance, penicillin allergy, although they might belong to the same family, but the cross-reactive allergy is like, I think 5 to 10%, if I'm not 5%, if I'm not mistaken, and GI tolerance. Otherwise, it's almost the same.
Okay, Dr. Mariam, when we get usually the sensitivity, you know, for the cultural sensitivity for antibiotics, what are the criteria of your selections for antibiotics? You are taking the least and you are leaving the big guns, or you are having certain criteria based on the patient profile? So what is your clinical expertise in these selections?
Yeah, so basically, definitely avoiding the most common leading to resistance. We're using the safest to the patient, according to the patient profile, and we're following up literally the guidelines. So basically, if I have a COPD patient with a clear pneumonia on a chest X-ray, if he's like 50 years old, he doesn't have any comorbidities other than COPD, doesn't have any vascular disease, I might go for just levofloxacin, or a combination of beta-lactamase plus beta-lactamamine plus macrolide.
Okay, thank you.
But in inpatient, we do respiratory culture in inpatient more, so it's very different. We're seeing a lot of resistance and.
Okay, Dr. Badr, regarding the improper dosing and duration, this is very common pitfalls in primary care, and not only by the physician but also by the patients. When they witness some kind of recovery, they omit, you know, they are not continuing the course that. So what is your comment on this, and what is your recommendations?
Thank you for this question, Dr. Ashraf. So, of course, as we know, most of the recommendations, they don't give you specific days sometimes. So it's a range between, like, for example, now they are moving toward, like, especially in UTI, less duration. So if you can see, the duration sometimes range from 5 days up to 10 days. It depends on the patient situation. Secondly, it depends on the physician believes and his old experience regarding dealing with certain cases. But I believe we need to take it case by case. That's why here comes the importance of close follow-up with our patients. So in some cases, we'll go for 5 days, and patient we extend to 7 days, okay? It depends on the patient case. So the minimum duration usually is 5 days. The maximum duration with some cases is up to 10 days. One of the pitfalls or one of the mistakes is from our side or sometimes the patient sides, okay, when the patient feels that they are good, or when they face some side effects, as Dr. mentioned, for example, from amoxicillin, okay, so the patient will stop after maybe 3 days more or less, and they will not come back to us. But here comes really the problem with reinfection again, or having the exacerbation of the disease itself. That's why close follow-up with the patient, number one, to see if there is any side effect or not, okay, to monitor this patient's signs and symptoms. Number two, this will help the physician to decide whether we should continue with the same antibiotic or not. Should we extend the duration to the max or not?
Thank you. Thank you. This will take us to the similar extension of the answer of these questions, the overall reliance on empirical treatment, Dr. Mariam. What are the consequences, and what are the situations where we have to do the culture rather than going for empirical treatment in primary care?
In primary care, so far, we don't need to take any respiratory culture. Unless the patient has been hospitalized over the past 3 months, or if the patient has a severe disease and he is an inpatient, at that time we ask for respiratory culture. Otherwise, as a community acquired in primary care, and the patient has not been hospitalized for the past 90 days, we don't need to do any respiratory culture. Actually, sometimes patients with bronchiectasis, we know that bronchiectasis is really common. Sometimes reflux might cause bronchiectasis, chronic reflux disease, some immunosuppression, in some COPD, in some asthma, in some like ABPA. We're seeing a lot. And in some bronchiectasis patient, I do respiratory culture, even in outpatient treatment. And if my management is failing, for example, I give them like 48 to 72 hours. For example, started on a combination therapy and he's not improving. At that time, actually, I upgrade a little bit, and then I do respiratory culture also, even sometimes without admission. And this is going to be based on really patient reliability and how frequent he will follow up, and is he serious following up. And sometimes, if the patient is not reliable, or I can tell that the family are not like there mentally, so I just admit them if he's not improving on outpatient management.
Okay,
for example.
perfect. Any additions, Dr. Badr, Dr. Muhammad?
Just one, Dr. Mariam, what about PCR multiplex? When you use PCR multiplex, it's a big area, and sometimes really you have different tests, okay, and it's available. So do you rely on that? When to use it?
PCR outpatient, we test only for influenza and coronavirus infection. We don't do, even in inpatient, we don't do multiplex PCR in the sputum. We use it only in deep tracheal aspirate, like tracheostomized or intubated patient, because we need a clear sputum from the inside, or bronchoscopic lavage or aspirate. So basically, we're not using it, still sometimes requested, but it's not recommended to use it in sputum, because you're gonna see most of the PCRs, 34 that comes from the sputum contains like 10 germs, and most of them are from normal flora or contamination, so it's not reliable at all. So only from deep tracheal aspirate or bronchial aspirate, or sometimes you do some nasobronchial aspirate if the patient is a bit sick and is not intubated. We need a deep sputum for that. Yes.
Yeah. Okay, I have a very interesting questions. I don't know whether it will, we have answered or not. The question says, guidelines often recommend avoiding broad-spectrum cephalosporin for uncomplicated upper respiratory tract infection. In what specific scenarios is ceftriaxone truly justified in primary care for uncomplicated upper respiratory tract infections?
So all the upper respiratory infections that we mentioned, okay, starting from sinusitis, pharyngitis, otitis media, okay, even tonsillitis, you can start, even if ceftriaxone has a place, okay, and it's really effective. The guideline still is not advising to start with it, okay, that's why it's a good gun, an excellent gun, that a second option that, or an option that you have, okay, you can use it whenever the patient can use it. So sometimes patient has an experience with like amoxicillin, they cannot tolerate the medication, they have side effect, or they have you have allergy. So we have the second option. Okay. Second point, okay, even if you want to use it with those patients, there is no harm, okay, it is effective, okay, and it gives a very good result even in a short duration. But it's still, okay, it's, this is the guideline. If you talk about the guideline, it depends on the best research, the best clinical practice, okay, and the patient preference. So we need to look at all of these three. Of course, as we said, okay, still the amoxicillin and clavulanic acid plus or minus is still the first line. But what is the percentage of patients that really can tolerate or can take all of this? This is the question, and here comes your clinical judgment as physician. There is no right or wrong in this, so it depends on your experience with the patient and the patient preference with past experience, and of course your clinical judgment with the case, especially okay, if it's severe case or it's mild to moderate case.
Excellent. Dr. Muhammad, do you have any comments on this?
What I would like to add is, same as Dr. Badr was mentioning, also guideline is not obligatory for the physician, it's just a recommendation. So I'm totally aligned with what Dr. Badr was mentioning. Yeah. Thank you so much.
They always say guidelines are not a railway.
Yes.
They are handrails.
100%.
So you have to put your clinical expertise and your clinical practice and the patient profile for this kind of judgment. All right.
One more point. Unfortunately, the guidelines takes into consideration studies done European or US or, for example, North America, etc. Latin America, Africa, Middle East, we're lagging behind in that area. So we're just following others' guidelines, and we don't really know what do we need to do. But it's working so far.
Okay. Dr. Mariam, what is the impact of the chemoprophylaxis in antimicrobial resistance?
Of?
Chemoprophylaxis. You know, we give antibiotics.
Okay.
Like, for example, during Hajj, we give, what do you call it, levofloxacin, for example,
Okay.
for meningitis, you know, as a prophylaxis. So what is the impact of chemoprophylaxis in general in antimicrobial resistance?
To be honest, I'm not really aware about giving levofloxacin as prophylaxis? You mean the patient in contact with the...
Yeah, for example,
people in
those
contact with
patients who did
someone-
not receive meningitis vaccine
okay, okay.
within 10 days.
Okay.
So we usually tend to give them one single dose of cephalosporins, for example,
Okay.
as a prophylaxis. Will
Okay.
that, highlight, the antimicrobial resistance as a major
I would say
component?
definitely. I would say definitely. If this is kind of like abuse of the antibiotic, definitely resistance will increase.
Okay.
Definitely.
طيب, I think if you don't have, we have one question here. تفضل. Questions?
Assalamu alaikum. First of all, I will introduce myself. I'm Mohammed Bargavi, senior medical rep from Sandoz Company. Dr. Mariam, just only I need to ask you about one question. I need you sharing with me your experience and feedback about the ACC long as mucolytic with COPD patient. Thank you.
Basically, most of the studies said there is no real difference between most of the mucolytics in the market and placebo. Okay, but surprisingly, you can say that some patients are really happy with it. Even sometimes are happy with the mucosolvan. For me, the most important mucolytics, to be honest, is hydration and fluid. And this is the only one that bypassed placebo by far in the studies. And sometimes even some nebulized normal saline and hydration of the lower respiratory tract is the better mucolytic. Actually, we're using nowadays the 7% sodium chloride nebulizer, mostly in inpatient and patient with like a lot of diseases and comorbidities, and it's working really well as a mucolytic. But to my knowledge, I did not review the latest study to be honest, but to my knowledge, all the mucolytics that has been in the market, even the guaifenesin, the Mucinex, etc., there was no real major difference between it and between them and the placebo.
All right, thank you so much. And we are coming to the end of this session, but before that, I would like to ask each one of you to give one single statement as a take-home message, one for upper respiratory tract, one for lower respiratory tract, and one for cefoxime for our primary care physicians, to have it along with them, with, as a take-home message to be practiced in their clinical practice. Dr.
Okay, so as a take-home message, close follow-up considered as a main part of the management. Okay, always I say to my patient, time is a management. So it will take time and you need to follow within the time.
Okay, thank you. Dr. Lower.
Basically, to start with, a good physical exam. It always helps with detecting pneumonias. And please don't label any patient as a pneumonia without having a clear chest X-ray with infiltrates, because it will differentiate our problem later on and our diseases later on and our management also and evaluation for that patient later on. So this is very important. And after that, I would follow up the guidelines. So practice in the safe side and take it individually, basically.
Thank you. Dr. Mohammed.
Well, I would like to mainly to focus on the heritage of cefuroxime with more than 35 years of experience and very good safety profile compared to third-generation cephalosporins.
Okay.
Thank you.
Thank you so much. So with this, I would like to conclude that upper and lower respiratory tract infection is one of the challenging clinical entities in our clinical practice as a primary care physician. We have to remember there is an abuse of using the overuse of the antibiotics that result in antimicrobial resistance, which is a major health concern, in fact, in our practice as a primary care physician. But again, we have to use the antibiotics safely and according to the guidelines and meticulously, because we should not abuse it, and we can make it as a available tool to cure our patients and to safeguard them from the consequences. We have learned from our expertise how to use the antibiotics, cefuroxime, in upper respiratory tract infection, in lower tract infections. We have seen the safety and efficacy profile of cefuroxime, so it can be used in our clinical practice without any concern, inshallah. With this, ladies and gentlemen, I would like to thank you for being with us here in this scientific event. I would like to thank our attendees online. I would like to thank also our society the Saudi Society of Family and Community Medicine. Thanks to Sanders for giving us this wonderful opportunity to be here together. And looking forward, inshallah, to get together again in other series and sessions of IMC Family Medicine Club. So stay tuned. We'll see you again. Have a good night, and thank you so much. Wassalamu alaikum wa rahmatullahi wa barakatuh.